Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good morning. Thank you for joining us for this live webinar to help you improve patient care thanks to a highly developed IDG team. Today, we will explore how prioritizing professional development leads to higher trust levels within teams and learn how patients benefit as well as satisfaction and quality measures improve. My name is Laura Barnett, and I'm on the marketing team here at Axxess. Before we get started, I'd like to tell you a little bit about Axxess. We're a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering hospice, home health, and home care providers to grow their business while making lives better. Today, you're going to hear from two industry experts. First, I'd like to introduce and welcome Heidi Wall. Heidi is the Director of Hospice Consulting for Healthcare Consulting. She has expertise as a hospice administrator, driving excellence in both patient care and operations. Joining her is my friend and colleague, Carol Javins. Carol is certified in hospice and palliative nursing and has 25 years of experience as a hospice nurse, started as a child, with extensive experience leading IDG teams. She's helped build our software platform, Axxess Hospice, and she now leads our hospice software implementation efforts. Before we get started, a couple of housekeeping items I want to make you aware of. Everyone's phones are muted. However, you may submit questions throughout the webinar by using the chat box on the right side of your screen. If time permits, our presenters will answer as many questions as possible at the end of the webinar, and if we don't have time at the end of the webinar to answer your question, we will follow up with you after today. Following our webinar, we'll provide everyone with a link to the slides and also post a video of the recording of the webinar on our website at axxess.com. Carol, take it away.
Thank you very much, Laura, and thank you, Heidi, for all of the really good conversations we've had in the research of a topic that's near and dear to both of our hearts. So today, the goals of the webinar, at the end of this presentation, we'd like you to be able to be familiar with why continual development for your IDG team is important and what are the potential pitfalls of not using these opportunities for growth with your team. We are going to discuss 4 different styles of developing your team members and help you identify when each style of development might be the most appropriate one to use with your team. And also, what I consider one of the most important parts of this is recognizing the situations in your day-to-day routine and the things you're already doing on a daily basis to provide the development opportunities for your team. So Heidi?
So why do we need to prioritize this development? That's a good question. Well, if you can imagine, we need to improve team satisfaction by cultivating professional growth and effective communication, attract and retain talent. So everyone wants to work where you feel professional, you are developed as a leader, as a team member, and you feel appreciated. So we want to develop and sustain trust between leadership and team members, and trust is developed over time. And once your team members actually observe you, prioritizing development and making trust a priority, they will actually honor that. And then ultimately, what results from all this is improvement in patient satisfaction and quality measures. And we are in the process of developing the next generation of leaders to address the aging of our nursing leadership. As we all know, that is happening. But ultimately, we're ensuring quality care for patients and families and fulfilling those ethical principles of nursing that we all cherish. So these are reasons to prioritize development. Carol?
So at the end of this, the end result of what we want to see when we're successfully developing our team is that we are going to have team members feeling supported and appreciated. There's a lot of studies out looking for what people feel they need out of leadership to be able to be successful and to feel valued. And they want to have the support, they want to have the appreciation, and they want to have the professional development opportunities. And when they have those things that they need, That's going to result in your loyalty of your team to your company and to you as a leader. It's going to have improved job satisfaction and the willingness to go above and beyond for your team and the mission. Hospice teams regularly will go above and beyond for their patients, but we ultimately want them to go above and beyond for their teammates, for their organization, and be able to help you with getting the mission and vision of your agency to be a priority and something that they're living on a day-to-day basis. Heidi?
So again, as we talk about why we should prioritize this development, what we want to do is make sure that we are ensuring that the right people are mentoring our teams. So if we are trying to develop our team, we want to have the right mentors in place. Our teams will provide better care, symptom management, and disease modification. This is a result. This is a great result of developing your team. This is what we came to hospice for, and to prevent inefficiencies at best and poor outcomes at worst. Better understanding of how each team member can impact the survey results and quality scores. So to know that they are invested, that they have a place on the team, and they can make an impact. And the costly effects of turnover, I once heard that it's between $50,000 and $70,000 to replace a nurse, even in a hospice situation. So that impacts morale and hinders your mission. If you are not only financially affected by that, but also morale, when people keep seeing people come and go and they're trying to develop relationships and formalize a team, that is definitely hindering the mission, and the patients and families do feel that.
One of the other things that we need to keep in mind when we're developing our team and helping grow the next generation of leaders is that we need to keep succession planning in mind. There's limited research on succession planning with the millennials, who are the next generation of nursing and social workers and chaplains, the whole IDG team. What do they need? We don't really know all of what they need to be able to feel like they want to step into leadership roles, but there's a lot of the millennials who are looking at different roles in healthcare rather than going into direct leadership, and we need to try and work on how to develop them into the leaders that we're going to need, because as the numbers here show, as of 2015, between 200,000 and 600,000 nurses are approaching retirement age, and the baby boomers are leaving the workforce. I'm a Gen Xer myself, and we're not getting any younger. We're becoming the middle-aged to senior leaders at some point here. So we need to make sure that we are developing the leaders who are going to replace my teams, the Gen Xers, as well as the baby boomers who are going to be retiring shortly. So succession planning is often an afterthought. We look at promoting someone who might be your best nurse in the field or the person who does very good documentation, but we're not always looking at the leadership qualities that we should be looking for to have leaders in healthcare, and we need to start doing that to be able to stop the crisis that's going to happen of having that vacuum of leadership.
So one of the things we do know that as far as what millennials do value is an authentic leadership. Authentic leaders are those, they recognize those that build and sustain healthy work environments with leadership skills that are refined, deliberate, and organized. They're very, very apparent. So they crave that mentoring and coaching and those growth opportunities which support the environment so that they can learn and prosper as nurses. They're invested in their careers. When supportive work environments don't exist for them, it shows that nearly 57% of nurses will leave jobs after 2 years of employment due to disengagement in the workplace. So if you think about that nurses are feeling like they're not valued, they're not invested in where they are, and they're just going to move on to the next best thing and keep searching for that. So we want to retain those people and develop them. So that is really what we're talking about today. Carol?
So what development style should be used at any given time? Well, and we're going to talk about the coaching, mentoring, training, and teaching in more detail, but when you're looking at, direct interactions with your team, training and teaching are the methods you're going to want to use for specific situations when you're training and teaching skills. But when you're looking at indirect interactions and the more that you're having to develop your team, you're looking at coaching and mentoring as the skills you want to be using to make sure that people are getting what they need in all of the situations, both the specifics and the overall development of their team. So with training, the first step is to look at what does someone need to be in a new role or a new hospice team, a new team in general, but it's how to do X, Y, and Z. It's not a discussion about best practices. It's not a discussion about what would we do in all of these situations, you know, X or Y. It's looking at if someone dies without an advance directive, what do you have to do? There's not a discussion, there's not a negotiation with this when you have to teach someone the protocols, and when someone knows what to do automatically in those situations. Why we run code drills in the hospitals, for example, is you don't want to have someone wondering what they should do. So this is a one-way interaction. The person doing the training is instructing on the policies and procedures and looking at teaching that skill. And we need to keep in mind that when someone is coming to hospice team, they're probably coming from some area other than hospice, and they really don't know what these normal policies and procedures and steps are in a hospice. So if we look at the fact that lack of knowledge is normal in those situations, then we're starting with the expectation that someone doesn't know these skills, and we're not going to be frustrated with teaching from the ground up because we expect them to not have these skills. Just like we have with our patients' families when we go into the house for the first time and we're teaching them how to use sulfate liquid. We don't expect them to know how to do that, and we shouldn't expect that our new teammates who've never worked hospice before know how to do these things that we want them to do in hospice as well. Heidi?
And so now we want to talk about teaching. And teaching is usually information from the knowledgeable teacher. So it's a more structured format framework for learning. So it's the prescribed path of how to perform, learning the right way to do something. Where do you find the resources? And so an example of this might be teaching someone how to take a referral in hospice. So if anybody in the office, that was something that we always expected, anybody in the office would be able to take a referral. How do you take that referral? What kinds of questions do you ask? A preceptor role for helping a new clinician gain confidence. This is a teaching. They're constantly teaching, the preceptor is, on how to document, for instance, eligibility. You know, what kind of information do we need to gather from those clinicals to put into a narrative, to put into our assessments? What are we looking for in the patient when we visit that patient for the first time? Just to document, how are they eligible for hospice? Why hospice? Why now? Best practices for documentation. We talk about documentation at point of service. You know, how do we do that? How do we approach that with family members when you take out your pad and tell them that you're going to be documenting? And then being proactive in the hospice symptom management. You know, what kind of things are we looking for with this disease, with this diagnosis? What kind of symptoms do we anticipate, and how are we going to manage those and teach families? This is all about teaching the right to do something, and if you do not know the answer, where you can find those answers. Carol?
One of my favorite things to do when I was running IDGs was coaching. And when you have a nurse who's been doing they've done the training, they've done the teaching, and now we're looking at how can we do goals for improving your performance. Coaching is a formalized few coaching sessions where you're discussing what the goals of your team member are and where they feel they would like to improve. And you work as the coach on how to help them achieve these goals. You're looking at a little bit more global. So you might be looking at communication with challenging family members. How am I going to have the conversation on admission where I'm discussing that someone is terminally ill when maybe no one has heard that before from their provider? And that's not as much of a step-by-step, but it's more of an understanding of where the patient and family are coming from and where is the clinician coming from. So you're providing the guidance to your clinician about how to be able to make the decisions on how to proceed. And with that, you're challenging the status quo of how they have always done things, and you're asking the more probing questions to help gain more insight and look for the possibilities of how different situations can call for slightly different responses. This is your one-on-one coaching sessions that hopefully you're able to have with your team on a weekly basis, on a monthly basis, depending on what the needs are of your clinician. But it should be focused often on what your clinician, what your team member feels that they need to be able to improve, helping them to work on having the best performance evaluation that they've ever had by being a proactive approach rather than a reactive approach where you're looking at performance improvement plans. Coaching can be a way to really get ahead of that.
Mentoring is a little more informal. It's a relationship. It's pretty much mutually agreed upon because when someone comes, a new employee comes on board, a new clinician, they're looking for someone to mentor them. They're looking for someone with that type of experience and knowledge and how to develop a relationship with that person so that they can be actually observing and practicing a lot of those ideas and interventions and the style of that person, and actually practicing those to incorporate it into their own practice and what will work for them. So that as they look at this, they're observing this. So one of the things is the mentor has to keep in mind to be mindful that others are always observing your actions and your words. This is that part of leadership where you're developing someone and to know that you leave a wake wherever you go and you impact everybody wherever you go, whatever decisions you make, even the expressions on your face. So when we talk about that, how to improve, like for instance, professional boundaries, when they are watching how you actually manage those boundaries when you're out with patients and you have another clinician with you that you may be teaching and mentoring. You know, they're watching how you respond to a patient when they say, "Can I call you anytime? Can I have your phone number?" What is your response to that? We want to talk about teaching, improving communication in challenging situations, and they're watching someone that you're mentoring is watching how you respond to that and learning how to develop those skills within themselves to actually see what works for them, what is natural for them. So mentoring is extremely important, and it's a lot more informal than some of the other things, leadership development that we do. Carol?
So when do we use each style that we just discussed here? And this graphic, I think, is wonderful for being able to show you how things change over time. When you have someone who's a new team member, either new to hospice completely, or maybe they have years of hospice experience, but they're new to the dynamics to your team, at first you're going to start out with that training and the hands-on assistance to make sure they understand your processes and your policies and how you expect them to be doing things in your organization. And then as time goes on and they increase their knowledge and experience, you'll move on to more teaching, and you'll have that preceptor out with them so they can be out in the field and working together on growth of knowledge and depth of knowledge. And then once they have all those basic skills that you're looking for on the how to do things is when you move more into the coaching and you're going into that higher level global thoughts of how do I improve, what are my goals, how can I be the best hospice clinician, hospice team member that I can be, and how can my leader help me develop into that. And as we move a little bit further on, your mentoring comes in as well, where they're looking for that person to be able to look at overall professional development and become a deeper, broader clinician who has the ability to then wind up mentoring somebody else and to be able to pass those skills on themselves. So where do we fit this in? Where do I have time to do any of these things? Because I know that when I was a team director, I was busy. I know you guys are all busy. When do we have time? Well, the thing is, you're already doing all the tasks that there's time to fit this development in. You just have to change your mindset to be able to be thinking about training, teaching, coaching, and mentoring when these situations come up. So now we're going to discuss the different things that you're doing on a day-to-day basis with your team and how you can be working those things in. Heidi?
So you do know that, in your day-to-day operations and your all the events you go through as a leader and your day-to-day organization, adverse event discussions do come up. These adverse events, like it or not, they do happen to us. But one of the things that we have to approach those is with a non-punitive tone to promote that improvement within our team. And then we want to gather the team together to get them involved in a discussion of that and identify. The discussion will lead to identifying any trends that might be occurring. So you're actually reviewing during this whole process the events that are leading up to the adverse event. What happened? And then what did the team do about those events while it was happening? And then what resulted because of those actions? What can we learn from those results? What can we do to change it in the future? Maybe do something differently. Or what did we do well, and how do we want to hardwire that and incorporate that into our process? So what ideas can we learn from this to grow for the future and how we actually handle adverse events and what kind of discussions we have? So in this whole process, what you're doing is, as a leader and you're leading this team for this discussion, you're actually mentoring, and then you're training them and what pieces of an adverse event we're actually looking at, and teaching them how this process works and how they can incorporate that into anything that might be occurring within their patient and family. And this is all part of that interaction. And you're coaching when you're asking, when you're trying to actually elicit input from the team, you're coaching them and tell me what happened, tell me how that worked, tell me what you were thinking at the time. Tell me what resulted from that. You're coaching during that whole entire process. So we're already doing these things, like Carol said, without even realizing it. So we have to look at what kind of styles are we using for that and developing our team with that. Carol?
So one of the most challenging things for all of my clinical teams over the years has been how to establish appropriate and safe boundaries. So when you are talking in different sessions with your team or on the phone calls when they call you and say something like, I want to be on call for this one patient 24/7. I think, we've really bonded and I want to be the one there all the time. And you're recognizing that this might not be the healthiest boundary for your clinician and for your patient, having that discussion right there when it happens about how to maintain the healthy boundaries. When you hear your staff giving their personal phone numbers to the patients and families, how can you discuss with them that this is going to impact not only the patient care, but it's going to impact their personal life and their ability to burn out much quicker and to be able to have compassion fatigue showing up when they don't have the ability to have the healthy boundaries. So talking with them as these situations come up about how to approach those situations. Like, for example, when I would go out with my team and they would see a family member ask me, so how can I reach you? Whenever I have a question, and I answer with giving the 800 number for my agency, because I want the patient to have the best care possible 24 hours a day, 7 days a week, 365 days a year. And that's not me at 2 o'clock in the morning on a Saturday when I'm asleep and my phone is off. And having them see from that example of how you're not telling them I don't care about you, you're telling them, I care about you enough to make sure that I always want you to have the best possible. So, and when you do witness a display of unhealthy boundaries, when maybe your social worker sees your nurse doing that, how to work with them on how to address that with their team members so that they can all have the most healthy boundaries possible. So depending on the situation, you might be teaching, you might be mentoring, you might be coaching, but definitely a lot of that is, going by the example of showing your team how to have healthy boundaries and not being afraid to discuss consequences of not having the healthy boundaries for your team.
And so, again, just like the adverse events, Complaints actually happen to us in hospice as well. But one of the things we need to know, the goal of when we receive a complaint and we're investigating that complaint, one of the goals, of course, is a resolution for that. How do we fix this? How do we address this actual complaint that came in, this information that we now have? But the other goal is actually to learn from the complaint. And again, like an adverse event, what kind of things could we have done differently? There's always a kernel of truth in complaints. I have never, ever addressed a complaint through the complaint process that we did not learn something from and probably change a process as the outcome. But we want to take, again, that non-punitive tone that's essential to learning so that we recognize it's normal. We don't do everything perfectly. Families don't always perceive what we are trying to say. So how do we learn from this? So being proactive with difficult patients is one of the things we do learn, is when families want to have, everybody wants to be there, the communication wants to be given, they want communication to be given to everyone in the family, looking at maybe we could have one advocate in this family that we communicate with, developing some sort of response to that and being proactive and understanding that the result of this may be negative if we don't address this right now, because we're always going to be leaving out some family member that's not there at the time and may receive information secondhand that isn't accurate. So how do we identify those takeaways from complaints and implement those changes? We're actually mentoring that with our team when we discuss that and go through the complaint process. This is often done well in like a staff meeting when everyone is there, every team member to hear that. And then you're coaching them and how might we have done this differently? Have an open discussion with your staff and talk about that. And then depending upon the complaint, there may be training, a lack of training that's recognized during this process is maybe that procedure actually wasn't handled correctly. Maybe we didn't know that pharmacy was open 24/7 and we waited till the morning because someone did not get the correct pharmacy list or something like that. So training and teaching can also be a part of this process. Carol?
So when you look at getting your survey result reviews, everyone wants that perfect survey and it's going to say everything was exactly right by all of your team at all times. Except that's not often the case, although those of you who get your perfect surveys, I am very happy for you. But we don't always have that. So what are we going to do with our survey result reviews? So generally we're writing our plans of correction and we're doing the in-services and having everybody sign off on their in-service sheet of what we discussed about our deficiencies on the survey. But that's an opportunity to also help your team understand the purposes of the regulations. Because if it's just a bunch of words on the page and it's just a signature on the sheet, it's not going to be hardwired into your team in the same way because it doesn't make sense. The why isn't there for them. So when you do go over your survey, talk about why. Why is it important to have the election statement be done on this day with this content in it and have them write their own physician into the list? Why is it important that we have an IDG meeting and discuss our patients no more, or at least no less often than every 15 days, so that everyone understands that there's a reason behind these. It's not random, although sometimes it feels like it with some of the surveyors. It can feel like it's just random punitive things that they're writing, but generally there is a good intent behind most of these regulations that understanding the why will make it easier for your team to incorporate those best practices into their daily routine. And often what I've seen is when you're discussing your survey results, someone's going to say, well, I didn't do that. It was someone else who did that, or it was this other nurse who did that. And that becomes a challenge when people become defensive, and having it non-punitive as much as possible to say, we all see each other doing these things, and we can all help each other rise up and do the best that we possibly can in being able to call each other when we see things that are not best practice happening with our coworkers, and having that be non-punitive as well. Having your team be okay with coaching each other. out in the field because you're not there all the time to see everything that's going on. But also when you're going over your survey result reviews, you also might find, just like with the complaint resolution, that there's some actual training that needs to be done, because perhaps what you find is that people don't all know how to measure a wound in the same way. And so there's inconsistencies across the charting that your surveyor notes. And that could be something that you say, I thought everybody knew that. We have to go back and do the training on that so that everybody is consistent with doing this wound measurements in the same way. And that can be something that you find from your survey result review as well. But it's important, in my mind, to make sure the why is always going to be there when you're talking to your team, because it's so much easier to follow something that you understand more than just things that feel like rote directions from your team. Heidi?
So hospice quality reporting, this review is done, again, something that you do as a leader in your program every day that you may not have thought about using leadership styles during this communication process, this teaching process, this mentoring process. But when we talk about the HIS and the CAP scores, when you're reviewing those with your staff and going over those, they need to know how they can actually impact those. How do their behaviors, how do their communication skills, their practices actually influence these scores, and why? Again, just like Carol said, the why of this. Why are the HIS scores important? Why are the CAP scores important? Maybe even bringing up Hospice Compare in your staff meeting and showing them, this is what we look like. On the internet, when people are pulling us up, this is what we look like. Why is this important? How can we impact this? And talking about that, maybe even personalizing those results. For instance, when patients and when family members are making comments, about the team, they're often positive comments. Every once in a while, we will receive a complaint through that process. But talking about personalizing, why did they like this nurse so much or this chaplain so much, and what was it that they were doing, and having a discussion about that. And then when we do get those kind of complaints, a lot of times we hear things like, well, they were just grieving, they were just sad, that's why they were angry, they expected too much. Well, let's dig a little deeper into that and figure out, first of all, this is going to impact our scores, and it's going to, go out there on the internet and everybody's going to see it on Hospice Compare, but how might we have changed their response? What is it they're really asking for? As far as grieving goes, maybe they feel like they did need more visits. Did we suspect that? And how might that have been communicated to us in a way, what could we have said to them? What is it that you need? How are we making you feel more confident about taking care of your loved one? And, talking about the plan of care, using the verbiage on the survey. So we're teaching them about what the survey contents are, what the actual HIS questions actually mean and what they're measuring, and then coaching them on how we can respond to family members so that they are used to hearing those words like, I'm confident in taking care of my family member. I do know what the plan of care is, and I am involved in that, and using those types of words. So that's it. Carol?
So crisis resolution, unfortunately, is something that seems to come up on a fairly regular basis in hospice. There's unexpected things that will happen despite our best planning to be proactive and have discussions and education about things. And a crisis could be something like a traumatic adverse event, like someone falls and has a fracture when they're receiving care. Unexpected death circumstances, like perhaps someone has a traumatic bleeding end of life in front of their family members or staff members, that's quite shocking to be able to see. Maybe there's a situation with one of your patients where there's a complaint where we have to do an abuse or neglect investigation that can be very hard for the family members and for the staff to see. Or maybe there's an emergency placement need that happens. I remember one situation I was in where we had a family member who literally died while my staff was out there trying to set up emergency placement for my patient, who was agitated, and their caregiver dropped in a seizure and died during the visit. Everyone who was involved in this case, from the patient to the person who was answering the phone calls, everyone was just so blown away and was required immediate response to take care of every single one of those team members involved in this situation, because that's not what you expect when you go out to take care of a hospice patient. So when a crisis happens like that, you need to jump in. You're a manager on duty, your administrator on call, whoever it is, and call in your support troops of your more seasoned staff to help each other. Anyone who can go out and be a support to your staff in those situations is incredibly important. You need to debrief on that. You need to go over what happened and how did everyone feel, because sometimes there are things like that that you just can't predict, and it's going to knock people back on their heels a little bit. So you need to be doing the discussions, the debriefings, and you need to talk about being supportive to each other, to take care of each other in that. And then after the feelings are coming out and people feel supported, is to talk about what we can learn from these situations, how we can grow as individuals and as to be able to help each other on that. And also, depending on what happens in the crisis, you might realize that there's some protocols that just we forget when something unexpected comes up and everything just seems to blow out of your mind a little bit, like the steps that you thought you taught people. You might need to go back and try and hardwire those a little bit more. But first, the most important thing with these crises is to make sure you're taking care of your team and your team knows how to take care of each other. Heidi?
Again, taking care of your team. When you are, as a leader, in your everyday work life, you are actually most likely going to be part of IDG discussions. Sometimes that's in the formal process of actually being in the IDG meeting, and sometimes it's not. Sometimes you'll be walking the hallway on your way to the restroom, and then there's your IDG right there, standing in the hallway discussing a patient situation. And you recognize, in either whether in the meeting or informally, that there's a lot of emotion involved in these kinds of discussions. You know, oftentimes things like there are young patients or children in the homes, there are tragic events that led to the hospice admission, maybe there was an accident, you know, maybe both family members, both parents are actually sick and on hospice. That's happened many times. Some cultural and social minority discussions, or maybe some uncontrolled symptoms that family members that don't want to give pain medication because they're afraid of overdosing the patients. And so your staff members are actually observing those patients in pain, and that's hard for them to watch. Or recognizing and processing team grief. You've had a patient for a long time. Maybe even a team member was working in the long-term care and actually took care of the patient before they came on hospice and before they started working on hospice. So they know this person a long time, and they're processing grief through that, the hospice stay for that patient. So there's several situations that might arise in an IDG discussion. I know remember there one time when there was a young man who had a family, 2 young children, and he did not want to die at home. He did not want his children to see him die at home. And so when he was getting closer, he wanted the staff to help him recognize when he was getting closer so that he could go into facility and die there. And his wife was really struggling with that because she wanted to be with him. She wanted him to be at home. And so the staff had there was a lot of emotion involved in this discussion, and how to resolve that and how to honor the wife's wishes as well as the patient's wishes. What was in the best interest of the family, and what kind of emotions brought up, because this was such a young family. But you're actually talking that through with your staff. You're mentoring them and how to have conversations, and what types of things we can really take on, and where are our boundaries in this situation, you know, as far as here we are professionals, and how can we help? Can we give them resources, and maybe allow the wife, some time where the children are actually actually being supervised so that she can spend more time in the facility with her husband. That was one of the solutions in this scenario that I encountered. So we're actually mentoring and coaching a lot when we're having those discussions with the IDG team.
So one of my favorite things to do as a team leader is to have my one-to-one meetings with my team. And it's also, as a person who has a supervisor, it's one of my favorite things to do with my supervisor as well, is to have these one-up meetings where it's really just about discussing what's going on with me, what's going on with my team, and how we can work together to improve everything that's going on with my day-to-day work life. So you can have those weekly, monthly, based on need, you know, your ad hoc meetings. Sometimes it's face-to-face, it's best face-to-face, but sometimes just calling and talking to your boss because you need to vent or process some things. The goal of these meetings should be coaching and working on development of your team members' priorities. When your team comes in, your team member comes in, and you say, what's a couple things that you feel you'd like to improve on in the next 3 months or in the next year so that you can feel happier and more developed as a professional, and then taking what they are looking at to try and grow and working with them as the person with the more experience to help them achieve those goals. Positive feedback is so important to be giving in these meetings and giving the reinforcement of the importance of the goals. And this is one of those things that our millennial teammates, like we talked about earlier, it's very important that they thrive on this positive feedback. They thrive on the one-to-one sessions where they feel like they're going to get the reinforcement of their efforts directly with their boss. So if you have a team member who does need a performance improvement plan, then you're going to have a slightly different focus, but it can be part, these one-to-one meetings can be part of that as well. So if you have a team member who's struggling, setting up these meetings to work on performance improvement and how can I help you with setting these goals and being able to achieve these goals can be the difference between helping a team member be able to grow and stay with your team versus having to be reactive and doing write-ups and having to lose a team member either because you're not giving them what they need to improve in their process, or they feel so discouraged by the punitive tone of all of these interactions that they choose to leave and go find another job. But coaching is so important in these sessions in that it's a collaboration and a discussion of how to make the job better, the performance better, your satisfaction better. And this is going to keep a lot of people much more happy in their jobs than waiting until their performance evaluation to get all of this feedback at the end of the year. And then they're surprised by all these things that show up that they didn't even know were a problem until they had that meeting with you doing their performance evaluation. Heidi?
So this is one of my favorites, is supervisory visits. It's getting to go out with one of your team members and actually seeing patients, being out in the field with them and announcing to them, hey, guess what? I get to go out with you today and see one of your patients and visiting with them. So you get to observe their bedside personality, and it may be different from what you see normally. Maybe this is a very shy and reserved person who is out there with family members and patients and actually interacting very well and promoting a sense of confidence in their abilities. And it's great to observe that and to see that side of that person. And you get to see when they use their skills and, you know, as they have conversations, as they assess the patient. This is really important for many millennials because they get to, this is a time when they get to receive direct feedback. When right on the spot, you can say, that was great the way you said that, the way you presented that symptom, and the way you talked about how it can be managed. And then you can also identify risk areas before the surveyor you know, actually sees them, and talk about maybe hand washing and how it's good to be washing your hands before and after patient care, not just before, you know, those kinds of things. Or maybe you're observing, you know, and this talk about teaching and coaching, training may also come in here too, because maybe you're actually training on a procedure. Maybe you're training on the bag technique. We've gone over this in policy, but here it is, and let's do it together here. You know, or maybe some infection control process, or maybe actually how do you actually implement the pain ad on a dementia patient? How do we observe this? Maybe we move the patient to see if they grimace. You know, doing those kinds of coaching and teaching and training, these are all 3 styles that you would use in a supervisory visit. A great experience as a leader and a great opportunity for one-on-one feedback, just like the one-on-one meetings, but this is actually getting to observe them out in the field, doing what they do best. Carol?
So QAPI is near and dear to my heart, and one of the best things that I have had with QAPI is getting as many team members involved in the QAPI review as possible. And yes, you have to have a IDG discussion of QAPI. Often what it is 5 minutes on going over some things, and everybody writes before there's team meeting, and then there's a bulletin board in the hallway that everyone points to when a surveyor asks them what they're doing for QAPI. But in the best case scenario, getting your CNA involved in your QAPI review, getting your volunteer coordinator involved in looking at these measures, because we often look at these things from a nursing perspective because it's a nurse often who's doing QAPI, but your CNA is down there in the trench and can probably a lot more about how come we're having an increased risk of infections lately, or how come falls are happening, because they're the ones looking at the environment. You have your volunteer coordinator who might be looking at the numbers and say, you know, I'm not sure those numbers look right because that's not what I'm seeing from all of my team when they're reporting to me. And getting everyone to get involved in that discussion, you can have a whole new insight into what measures you should be taking to be able to improve your QAPI. But the best things I've had is having my CNA say, I'm going to take ownership of the fall prevention measures, and I'm going to make sure that in all of my nursing facilities, I'm going around and checking the fall prevention equipment is there, and everybody's alarms have batteries that are getting changed, to be able to see that they have the impact on being able to make a difference in these measures. But in order to do that, you have to first have them involved in the discussion and then coach them as to how every individual person who's on the team really does make a difference in your QAPI scores. Heidi?
So we're talking about quality assurance in that process. Within that process of the QAPI program, you know, we're identifying, we're assessing our documentation, we're actually reviewing that. And this is a great opportunity to be teaching and training with the team. So you are looking at things like eligibility documentation, and you're reviewing that with them. This is an opportunity to go over, you know, what types of things do we want to include in that eligibility documentation? What is a good example? What team member does this really well? And you know, actually demonstrating that to them, writing one yourself, practicing those, and comprehensive assessments and plan of care development, talking about how the assessment and the plan of care ties together and why this is so important. Everybody has the dreaded plan of care, but if you actually delve into, this is your prescription for your care. The plan of care should tell you everything about that patient, why you are visiting the patient, what is the focus of your visit, what are you doing there, what are the results of that, and what are you going to be doing going forward. That's the bulk of it. That is why we do what we do with hospice. So it's a chance actually for you to document that. So that's why it's important. Again, the why. You are actually teaching on the why of all of these things, the physician orders, why documenting those accurately, timely is extremely important, why the death and discharge documentation is important. A lot of times for discharge, live discharge, it has to do with continuity of care, and death documentation, you're actually talking about, it's a transition to bereavement, so it's a time to talk about how they handled that death, what happened at that death, and you're summarizing your care at that time so that anybody looking at that chart later, any attending physician who may be receiving a copy of it, knows what did hospice do for this patient and this family? You know, why are these things so important? There's so many pieces to the QA process, and such an opportunity as a leader to do that teaching and training role in this process. Carol?
You know, and to further on this, Heidi, on the QA process, one of the things I've noticed over the years with my team managers who've worked under me is often what they do in the QA process is they go through and correct the mistakes of their team over and over and over and over again. And when I've asked, you know, how come you just keep fixing those frequencies that aren't right, or you keep fixing those, that eligibility documentation that for the nurse, and they say, well, it's just easier that way. And it's easier in some ways, but you're going to be taking so much time that you could be doing other things, and you're taking that time instead of taking it to educate your team so that they stop making the same mistakes over and over again. You're taking time that you're spending to correct mistakes, and it feels like that it takes less time overall to be able to teach them so that we can stop having the same mistakes over and over again.
It's the goal of being proactive rather than reactive.
Absolutely. So with KPI review, so your key performance indicators is something that a lot of your IDG team members don't see how it applies to them. And when I've tried to work KPIs into my team discussions, I'll have CNAs or chaplains or someone who's like, well, what does this have to do with me? This is your financial goals for your company. But being able to get them to understand that it's everyone's responsibility to check and see if the patient has everything they need before the end of their visit. Like, do they need supplies? Do they need medications? Are they going to have something that's going to be a call for an extra visit or a stat charge on Saturday at noon or 2 o'clock in the morning on Thursday that we can be proactive on? So being able to review the standards of what we expect for these KPIs with teams so they understand how everyone's contributions impacts the KPI, that the CNA does have a role in being able to manage the supply costs, because if we don't do that, there's other things that we want to do for our team that we're not going to be able to do because we're not meeting these key performance indicators on other financial goals. You know, and then maybe we should look at, maybe no one ever taught my CNA how to do an inventory of supplies. They have no idea how to do that. They don't know how many diapers a patient is really supposed to have when they're at the nursing home. But I bet that CNA knows where those diapers are at that nursing home when we keep having to send them, if we just ask them and involve them in the KPI process. So if as part of the performance ratings for our field staff, we need to make sure they understand what they are so that they can know how to improve their performance and to improve the performance of the entire agency with this discussion. So mutual feedback of the team members with each other can really help with that as well. Talking to your chaplain about asking if the patient has all the medications they need before they leave at the end of their visit, and they can call each other on those things and help build each other's performance as a team. Mutual coaching amongst your team members is something that can be extremely beneficial there. So in summary, we're going to hope that after we've gone over all this information that you're going to be able to see how the development opportunities of your team is going to benefit you as a leader, because it's going to help you with planning, it's going to help you with team retention, it's going to help you understand how to best keep your team satisfied. It's also going to help you identify what the strategy is that you need to use in each situation. Do you need to be training? Do you need to be teaching? Are you coaching is the best thing that you should do, or is it the formal or informal mentoring that's the best strategy in that situation? And you're also going to be looking for opportunities in your daily hour, because you do these things every day. You're doing QA, you have to do QAPI, you have to do adverse event discussions. How can you look at those in a new mindset as teaching and development opportunities rather than just something that you need to get through and write down on paper? So we're hoping that that's what you'll get out of what we just went over. And you know, as you can see, there's a quote here from Heidi that I actually included when we were discussing all of this, and I told her I'm not only putting it in this presentation, but I am attributing the quote to her. And that knowing what you want to do as a leader is not enough, what you don't want to do. You've all had those leaders that we know, oh, I don't want to be like that person. But that's not enough. You have to know what you do want to do, and you have to be deliberate in learning the skills required to be an effective leader. It's not just about what you don't want to do. How can we put the effort in to be a deliberate learner of the skills of being a best leader and developing your team? And Heidi said that so beautifully, so I absolutely have to end on that. And I want to thank Heidi for all the wonderful discussions that we've had on this topic and being able to help each other grow through this process.
All right, thank you both, Carol and Heidi. We appreciate you taking the time to share your wisdom and your insight about educating our teams and growing as a leader. Don't forget, we're going to provide everyone with a link to the slides, and we'll also post a video recording of the webinar on our website at axxess.com. Thank you so much for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a fantastic day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.